of everything is this inflammatory lid margin disease called blepharitis. So we wanted to kind of go into depth of that. From a study in 2009, George Washington University, 1/2 to 2/3 of all patients have some form of blepharitis. And this is thinking of the traditional definition of the word. Keep in mind, this is a decade-year-old study, so things such as digital eye strain have kind of upped those numbers. But once we rethink the definition of blepharitis and kind of expand it beyond really heavily symptomatic, those numbers will go way up. So I would say close to 80 to 90%, if not higher, have some form of inflammatory lid margin disease. If you've heard the word dry eye disease, I want you to start thinking about it as the word dry eye and blepharitis syndrome. So blepharitis and dry eye are traditionally considered two different disease modalities or two different disease processes. I'm going to show you tonight that if you've been diagnosed with blepharitis, there's a good chance that you could have dry eye as well. And if you have dry eye, if you've been diagnosed with it, you have blepharitis. Blepharitis is an early onset and an early manifestation of dry eye disease. It's the same disease. This right here is what ophthalmologists and optometrists are explaining to you, or attempting to rather. This is something called DEUCE-2, which is a medical conference that is focused on dry eye, and this is what some of the doctors came up with when discussing dry eye disease. And it's very, very complex. It's hard to follow. And as the patient, it would be even harder for you to understand because you don't have that medical background that these doctors do. What I want to show you is this right here. Okay. This is the theory of dry eye and blepharitis syndrome, and it starts at the bottom with bacteria. And bacteria, in order to survive, they create something called a biofilm. And this biofilm houses and protects the bacteria and allows them to increase their population densities. And they go through this process called quorum sensing gene activation, which allows them to start producing toxins. Okay. And these toxins are what causes the inflammation. So earlier in life, when you start developing signs and symptoms of blepharitis, it's primarily focused and gets into the lash follicles. From the lash follicles, this biofilm will spread to the meibomian glands and start affecting and shutting those down. Eventually, this biofilm will creep over to the lacrimal glands and affect those as well. And if any of these gland names are unfamiliar to you, the meibomian glands are the glands that produce the oil or lipid component of your tears. The lacrimal glands create the aqueous or water component of your tears. And these two components also with the mucus layer form your natural tears. So when you're deficient or lacking in something, that's what causes some form of dry eye disease for you. So what I'm going to present to you guys, it's really nothing new. It's not reinventing the wheel. It's no groundbreaking research. It's taking existing concepts that have been around for a very long time and putting them together. So lid hygiene, as I'm sure most of you are aware that suffer from this disease process, it's been around for decades. Inflammatory dry eye or lid margin disease, that as well has been around for decades, knowledge about it. Biofilms, we've known about those for centuries. Quorum sensing gene activation, this is probably the most recent research developed by a scientist at Harvard in 1968, John Woody Hastings. And Staph aureus virulence factor. Staph aureus is the bacteria that's really the bad guy that's causing a lot of the inflammation through its exotoxins and virulence factors. We've known about those for a long time as well, decades. We're taking existing research and putting it together to tell a new story, a story that's easier to follow along. To change the way that we understand and get our dry eye treated simply requires a reevaluation of existing evidence, common sense, and intuitive reasoning. Nothing really more except for the want to. Your doctors have to want to treat you differently. They have to want to understand the disease process better. They have to want to give you something more and beyond traditional lid scrubs, or traditional means of treating blepharitis and dry eye. So coming back to blepharitis, let's talk a little bit more about the biology of the biofilm. Inflammation is the endpoint. So what is the start point? Well, the start point is going to be in this biofilm. And I keep saying that word biofilm. It's very important that you register that because this biofilm protects and houses the bacteria and makes it so that really anything that we try to throw its way doesn't do very much good. Virtually all bacteria produce biofilms, especially Staph aureus and Staph epi, and these are two main bacteria in the biofilms that exist on your lids. This biofilm provides protection against the host, so your host response, your white blood cells, your leukocytes, are unable to penetrate this biofilm once it's in place. And this biofilm begins shortly after birth. Okay, so shortly after you're born, it starts to develop, and I'll show you how and why it becomes problematic later in life. So the biofilm, a very common biofilm is plaque on your teeth. That's a biofilm that causes an inflammatory disease similar to blepharitis. Gingivitis is very similar to blepharitis. The way that we need to think about this biofilm is when you're younger or it's not producing, it's not problematic, it's like a single story home, okay? But as the population and as the biofilm increases, it becomes more like a multi-story apartment complex and is able to hold a lot more of these bacteria. It's made of a polysaccharide, so it's made of a sugar substance, and it just gives a thriving environment for more bacteria to form. This is a study that's, I present this deck to doctors, and what this study essentially says that after cataract surgery, after uncomplicated cataract surgery, bacteria and biofilms still exist, and the bacteria still exist because they're housed within the biofilm. So it's showing that any of you that have received cataract surgery, anything like that, you still need to get something that removes the biofilm because it's still housing bacteria. Biofilms grow virtually anywhere in almost any environment where there is a combination of moisture, nutrients, and a surface. So if you find these three elements anywhere in the environment, you are going to develop a biofilm. So they're at the bottom of the ocean around deep sea vents and glaciers in Antarctica. Plaque on your teeth. Once again, I'm going to keep coming back to that one. Plaque on your teeth is a biofilm. If any of you have a dog, during the summer, you've got a dog dish, a water dish outside, and you toss out that old water and you feel the bottom of the dish. Well, what is that? It's a slimy substance. That's a bacterial biofilm. I don't know how many of you are in the South, but during the summer, we wade through creeks. And if you've ever slipped on a rock and gotten that slimy feeling on a rock, that's a biofilm. Now, the rock isn't inherently slippery. You look at the ones that are on the bank, and if you don't get in water, it's just wet. It's not necessarily slippery. The reason it's slippery is because it has biofilm. This right here, this is a industrial pipe, and this is biofilm that has collected waste and just collected things throughout the years. The reason that this pipe is here is because very similar to a pipe, our meibomian glands work in the same fashion. And if biofilm is able to creep over these glands, they'll essentially block them and shut them down. Pacifier right here. You know, we take very good care of our children. I've got two kids myself, and with our son, our firstborn, we would always sterilize anything that fell on the floor. You know, if a bottle nipple fell on the floor, if a pacifier fell on the floor, we'd take care of it, put it in the sterilizer. Our daughter came along, our second-born. She would drop a pacifier on the floor, and we would just kind of brush it off, clean it off, not put it in the sterilizer. But this shows that maybe we should have, because this has a thriving biofilm that exists there. So if it goes unwashed, untreated, without physically removing that biofilm, it's going to congregate and just expand from there. Sink strainer. I don't know if I've ever thrown one of these out, and maybe I should, because once you put it under a microscope, look at that. This too has a biofilm. It exists everywhere. What about this guy right here? This is a lid margin. So if you look right here, you see biofilm. It's kind of that greenish color stretched across there. But once it kind of flakes off, and once oxygen hits it, it oxidizes. So any of you that have those symptoms of, and I'm going to use this terminology, but I don't want to use it again, but scurf or debris or lash dandruff or mattering or crusting, any of the stuff that exists there, well, what that is it's biofilm that was once tightly adherent to your lid margin. It's gotten some oxygen in it, and it's now scattered throughout your lashes. That's what we're seeing here. So we've been talking about increased density in bacteria, which are normal flora. You know, they exist there. They're supposed to exist there. Why do they become problematic when they increase their densities? Well, quorum sensing gene activation. And this is a process where once a population of bacteria reach a certain density, they start producing virulence factors to liberate new food sources. Once again, bacteria are just trying to survive. So this is how they chemically communicate with each other to destroy the host tissue to get new food. They produce exotoxins, lipases, superantigens. Toxic shock syndrome is a superantigen that is produced by Staph aureus, and it's actually the same superantigen that's going into your meibomian glands, your lash follicles, your lacrimal glands. It's really bad stuff. It's chronic and low grade, but it's bad stuff over a long period of time. The way that I like to think about quorum sensing gene activation. So there are now 7 of us in this webinar. So let's say the 7 of us are in a biofilm. We're in a happy little biofilm. Everything's fine. Well, if we turn the 700 of us into 7,000 of us in that same space, well, suddenly we don't have as much room as we used to. We don't have as much food sources as we used to. So we're going to start chemically communicating with each other saying, hey, we've got a problem. We need to do something. And we're producing these toxins which break down food sources and allow us to expand and survive. So we're going to talk a little bit about the bacteria that exist within the biofilm itself. Staph epidermis. Um, I'm sorry, Epidermis. It's a primary biofilm former. So its role is to create the biofilm, create the structure in which this population will thrive. And they also create a moderate cytolytic toxin. So they produce a little bit of a toxin, but it's not really the bad guy in this partnership. This is the builder. This right here is a Staph epi biofilm under a confocal scanning laser microscope. So it lets you know it's small. It's a very small sort of thing. Now let's get to the bad guy, the virulence factors of Staph aureus. So what Staph aureus creates are adherence factors or adhesins, which is like a biological superglue which latches this biofilm down onto your lid margin. Okay, that's why if you were to just simply use lid scrubs, if they were effective, you wouldn't be able to just get it off because it's an industrial superglue. It's the real deal. And that biofilm isn't going anywhere. More importantly, with the Staph aureus, they create exoproteins, exotoxins, some of the exotoxins, the superantigens that they make, toxic shock syndrome, food poisoning. Next time you guys get food poisoning, you can thank Staph aureus, scalded skin syndrome. All of these enzymes, nucleases, proteases, lipases, all of these bad things, all these toxins, which are chronically and consistently beating down on your lash follicles, on your meibomian glands, on your lacrimal glands, on the structure of your lid, constantly beating it up. You can imagine, this is why you're getting some pretty severe signs and symptoms of blepharitis and dry eye syndrome. This right here is an interesting slide. So this is a biofilm, once again under a confocal scanning microscope, and you see these green dots. All of them are kind of laid across, but none of them are truly penetrating. And the reason for that is this biofilm doesn't allow anything, including these human leukocytes or white blood cells, to penetrate the biofilm. This is why if your doctor has prescribed antibiotics, you might have felt some short-term relief, but you're not feeling long-term relief because it's unable to penetrate the biofilm. Okay, so it's very important to note that if you're only getting sent home with antibiotics, yeah, you might feel better for a little bit, but with the long term, with the long game, you're not going to feel any better. Deng Xiaoping, hide your strength, bide your time, was a popular saying from him. And obviously, with communist China in the 80s, he was talking about more of a technological or a military strength. Well, if we refer to it in terms of the biofilm, then we are talking. Oh, oops, hold on a second. Okay, sorry about that, you guys. And I just wanted to check real quick. Can everyone still hear me? Let me. I'm going to give it a break real quick. I'm going to come back to this slide particularly, but I just wanted to make sure and go to the chat or the questions. Yes. Okay. Oh, perfect. And I'm sorry. Let me see, Dr. Baker. Could you first? Oh, I'm sorry, you guys. I just kind of led in with all of that. So this is Christopher Whitehurst, you guys. I am the clinical director of training for Blepharitis. I'm actually the one that goes out and trains ophthalmologists and optometrists. Dr. Reinerson will be joining us at the tail end to answer some of your questions. But just because this is a presentation and a slide deck that I present literally on a daily basis, I just wanted to get the opportunity to give you guys some groundwork before you started asking questions about what you've learned here. Dr. James Reinerson is the ophthalmologist that will be joining us here in a little bit. He is the ophthalmologist that came up. Well, I don't want to say came up. That doesn't sound professional enough. I did the research and developed the theory of dry eye and blepharitis syndrome and how biofilms play a factor in there. And this is research that's been ongoing for about a decade now, and it is becoming the gold standard of understanding when we talk about blepharitis, dry eye, and biofilms. So there's a little bit of an introduction about myself, and you guys are more than welcome to kind of put in the chat box so I can see, who you are, where you're from, and what your signs, symptoms, what you've been dealing with. That way, when we answer some questions, we have a little bit more than just a first name basis. Okay. Oh, Shaka, you're in Pennsylvania. What part of Pennsylvania are you in? Because I actually I just left Pennsylvania yesterday. I was in Philadelphia, and now I'm in Baltimore. State College. Oh, yeah, that's right. You had written in that the Nittany office. Okay, yep. Okay, great. So let's jump right back into it, you guys. We'll talk about. Let me see. Make sure I'm still sharing my screen. Oops. Maybe, maybe not. What have I done? What have I done? Sharing. Play. Okay. But let's go back a slide. Xiaoping, hide your strength, bide your time. The reason that we have this quote in there is because bacteria are essentially doing their same thing, the same thing. If we have this 5-year-old that has a biofilm forming, and we have Staph aureus and Staph epi that exist there, and they start producing these toxins that we speak about, the host response will come in and wipe them out. Okay. There's nothing to protect the bacteria. Bacteria, once again, everything starts with bacterial survival. So they create this biofilm to protect themselves. Okay. Once again, the biofilm can't be penetrated by antibiotics or by white blood cells, so they create this biofilm in place to protect themselves. Stages of dry eye and blepharitis syndrome. So I'm going to use some terminology here that you might not have heard of, and then I'm also going to use its counterpart that you probably have heard of. So stage 1 of dry eye and blepharitis syndrome is folliculitis. Okay, this is follicle edema. This is lash loss. This is where that debris, that mattering. You might have heard it referred to as anterior blepharitis. Okay, you might have been diagnosed with that. Well, anterior blepharitis doesn't mean crusting or debris in the lash line. It means that there's any sort of inflammation in the lashes, which can also mean edema. Stage 2 is meibomitis, and this is really the start of dry eye disease. So you might have been diagnosed with dry eye disease or meibomian gland dysfunction. This is when the meibomian glands start to be affected by the biofilm, and we start to lose that layer of lipid or oil. That's why when you probably have gone into your ophthalmologist or optometrist and you say your eyes are watering all the time, they look at you and say, well, you have dry eye disease. And dry eye disease doesn't mean that you're completely deficient of any sort of moisture. It means that you're deficient of one of the components of your tear. Stage 3 is lacrimal. Oh, I always mix this one. Sorry, guys, it's been a long day. Lacrimal. You might have heard this as aqueous deficiency. This is when you start to lose your water component of the tear. So meibomitis is when you lose the lipid layer or the oil. Aqueous deficiency is when you lose the water part. And stage 4 is lid destruction. That's more about the physical anatomy of the eyelid, and yes, that does play a factor, but I really want to talk to you guys about stage 1 through 3 because this is what more than likely is affecting all of you. And right now, folliculitis, meibomitis, lacrimal, or anterior blepharitis, posterior blepharitis, and aqueous deficiency are all thought of to be separate disease processes. Well, I'm going to show you through this, and this is what you can go back to your doctors. I don't care. You can tell them to call me up. This is what a lot of doctors are calling a separate disease process. It's not separate. It's just different manifestations at different periods of time. And I'll come right back to that question here in a second, you guys. Folliculitis will always be the first manifestation of inflammatory lid margin disease due to anatomy. So the biofilm, or the plaque that I keep harping on about, it forms on the lid margin. It forms on the top layer. And I thought I could, okay, I can't highlight it, but on the surface. And this biofilm creeps down into the lash follicle. So where your lashes grow, it's going all the way down to the root or the bulb, and it's existing there. And it's releasing these toxins in there, and that's what's making you lose your lashes. That's what's causing the swelling at the lash base. As your lashes grow, they pull off the biofilm, okay? And as they pull off the biofilm, like I showed you in that slide prior, it oxidizes, it turns a yellowish kind of sticky color, and that's what you see as the mattering or the crusties or the debris. Now you know it's eyelid plaque, which is biofilm. This is a Caucasian patient on the left and a African American patient on the right, and both at the base of the lashes, you can see edema or swelling. Well, if you see edema or swelling, that means there's inflammation. Same thing with anything else, medically speaking. If there is edema, there is swelling. If there's swelling, there is inflammation. And a lot of these patients, I myself, I'll show you here in a little bit, I have edema or swelling at my lash follicles, but I don't have any other signs or symptoms right now. It doesn't mean that I don't have blepharitis. It means that I'm not symptomatic right now. It means that my doctor should have a conversation with me and let me know that I have inflammation. It's going to get worse for me if left untreated. And that's what so many of you have had to deal with, is you've had this inflammation for a long period of time, but you weren't diagnosed until you were heavily symptomatic, in which case it is an uphill battle. I hate to go this route and compare it to something as severe, but think of it almost like the stages of cancer. Stage 1 cancer is a lot easier to treat than stage 4. And that's kind of what we're dealing with is a lot of patients are waiting for their stage 4 blepharitis or dry eye disease before they're being taken serious and getting treated. This right here, this is a good slide that shows you this mattering. This is biofilm right there, that kind of yellowish scaliness that has been pulled off of the lid margin and oxidized. When it's tightly adherent on the lid margin, it's nearly invisible. You can kind of see it with a little bit of staining, and you can kind of see it as a sort of crinkly sort of fixture on the lid margin. But once it oxidizes, it is absolutely visible. Once again, on this patient right here, you can see lash misdirection. You can see edema or swelling at the base of the lashes. So this shows that this patient does have swelling and inflammation. Lash dandruff. I don't know how many of your optometrists or ophthalmologists are using this terminology. Obviously, what you are experiencing is not dandruff. What comes from your scalp is dry, flaky skin, and that's not what we're dealing with here. This is obviously sticky. It's not the same component. Dandruff is a lazy word to describe it. Another lazy word is debris, mattering, scurf. Scurf is another kind of lazy one. We know that this is a plaque. Just like plaque on your teeth, this is plaque that exists on your lid margin that can also be in your lash follicles. So that covers stage 1, folliculitis. Stage 2 is meibomitis, or meibomian gland dysfunction. So what we're looking at here, you guys, is a cross section of the lid margin. So if you look there, 6 is our lash follicle. That's our eyelashes. You can see in comparison to 5, which is our meibomian gland, the meibomian gland is a huge structure in comparison to the lash follicle. So it shows you that it's an easier access point at the lash follicle. It's a bigger opening. So this structure is going to be taken over a lot easier and a lot quicker than 5, which is the meibomian gland. But over time, this biofilm is going to creep over the lid margin. It's going to kind of block the surface of the meibomian gland, and then it's going to fuse its product, its biofilm, and mix with the meibum that is in there. So I showed you the slide before of the industrial pipe. You can kind of see here that if this was a pipe all the way through and through, and biofilm was down in there, that eventually it would be blocked. And if we block the meibomian gland, we are not allowing the meibum or the oil layer to express. So this right here is it's an early onset of meibomian gland dysfunction. You can kind of see those white creamy dots, and those are the exits or the meibomian gland openings. Well, with this patient, the biofilm has gone on top of that, and it's no longer allowing it to express that the good oil that needs to be in the tear. When meibum is a healthy product or not contaminated, it kind of looks like olive oil. You'll see in a couple patients what diseased product looks like. Something that's very important to note, any of you patients that have been diagnosed with only meibomian gland dysfunction and no form of folliculitis or anterior blepharitis, I almost guarantee you that your lids will look something like this or worse. Now, if you haven't been diagnosed with anything on the anterior section, I want you to look at this patient right here and look at the base of their lashes. And I wish I could show you on a laser pointer right now, but all those lashes on the left side, there is edema or swelling, which equates to inflammation. So this patient that might have been diagnosed with meibomian gland dysfunction should have also been diagnosed with folliculitis, because they have inflammation at the lash follicle, which it started there and then creeped over to the meibomian glands. It didn't just start in the meibomian glands, it made its way there. Some of your lids might actually look like this. And what we're dealing with right here, we are looking at a meibomian gland that has been blocked over a longer period of time. So as I said, the oils aren't able to express out of there. Okay, so they're trapped. They're trapped within that industrial pipe. Well, as the product continues to build, it wants to go somewhere, so it's trying to force its way out of this gland. It's unable to do so because it does have this biofilm in place. I'm sure a lot of your lids might look like this. Once again, I want you to notice all the inflammation along the vessels itself, and also look at this patient's lid margin. Okay, so this is a patient that once again has the old words of anterior and posterior blepharitis, or what needs to be used, lateral folliculitis and meibomian gland dysfunction, or meibomitis. This is a great slide right here. A lot of your glands might look like this as well. These are glands that have almost gone as far as they can go with trapping this meibofilm, this mixture of meibum and biofilm, gone as far as it can. And some of them you see right here, it's auto-expressed. It's expressed itself because it's pushed as hard as it can. And this product right here, it's like a toothpaste. So I told you before that a healthy meibum is going to look like olive oil. This product right here looks like toothpaste, looks like sludge, and that's because it's become diseased and it's become a mixture with the biofilm. A great way to think about what these glands are going through is if you had a tube of toothpaste and you put some saran wrap on top of it and you squeeze that toothpaste, well, what's going to happen? It's going to dome up a little bit, but the toothpaste isn't going to come out. Well, over a period of time, if you continue to squeeze that toothpaste, eventually that saran wrap is going to bust and it's going to allow that toothpaste to come out. And that's exactly what is happening here is your healthy oil product from your tears has turned to a toothpaste-like substance, and it's not able to express out onto the where it needs to go. In addition to that, when you have a deficient lipid layer, you have less natural antibodies. And when you have less natural antibodies, you have less natural defense to fight against this biofilm that's forming. So once again, going back to Deng Xiaoping, it's almost like this is a perfect war strategy. The biofilm is taking over and shutting down the defense systems of the body to make it easier for this biofilm to spread. Okay, so moving on from there, I don't know how many of you guys have gotten some form of expression. And a popular term right now is keratin capping. And by keratin, we mean like skin, capping over these glands that coincidentally place themselves on top of these glands and only at these glands because keratin doesn't exist anywhere else in this segment of the lid margin. It's not keratin. What it is it is biofilm that has gone on top of the meibomian glands and trapped it. Okay, so it is not keratin. It's biofilm that is housing in or preventing the meibofilm from expressing. And that's what causes evaporative dry eye. That means that you only have the water part of your tear. That's why a lot of you guys, it feels like you're looking underwater because you essentially are. You're only dealing with the aqueous part of your tears. So what we're looking at now is stage 3, and this is lacrimal. So we're not talking about the big lacrimal gland that expresses when you cry and whatnot. We're talking about the everyday tears, and these are called auxiliary lacrimal glands. These are what produce the water part of the tear. So this biofilm that is on the lid margin, once again, this is a cross section here. It's already taken over the lash follicles. It's already taken over the meibomian gland, and you can see it kind of highlighted in red right there. Well, this biofilm is going to keep moving and keep marching onward, and it can do that through 2 possible ways. The first way is it'll flake off, kind of like a tumbleweed going through the desert, and it will go up to the lacrimal glands and affect them from there and spread and take over. Another way is if it just creeps along the back of the lid through direct extension. Either way, it's going to get there and it's going to take over that gland and it's going to make it so that you no longer have the aqueous component of your tear. So this is a patient right here that would probably be diagnosed with aqueous deficiency because if you look at the top of the picture, they don't have a tear lake or the water component of their tear. Now, heaven forbid any of you are at this stage of your disease process. If you are, I truly apologize for the medical community not doing better for you. But I really want you to note all of the different levels of inflammation for this patient. Okay, there is inflammation at the vessels where the meibomian glands should be. Meibomian glands are no longer present there. They're fibrosed. They're dead. Doesn't mean that this patient is not or did not have meibomian gland dysfunction or meibomitis. It just means that it went on for so long that it destroyed the structures entirely. Another thing to note, if you look at what lashes this patient has left, there is edema or swelling there. Absolutely, this patient has folliculitis. The only thing that this patient really doesn't have is that crusting, that mattering, that plaque. And the reason for that, in order for it to be pulled off of the lid margin, as we said before, where air gets underneath the biofilm and makes it visible, these lashes have to be growing, and these lashes are absolutely not growing. They're barely clinging on for dear life. In addition to that, in order for a biofilm to form, it needs the bacteria need water, they need nutrients, and they need a surface. So they still have some nutrients here, and they still obviously have a surface, but because we've affected the aqueous, the water component, bacteria have now become their own worst enemy. They've eliminated the moisture that's necessary for their biofilm to thrive. And we hear all the time, we're destroying the earth, we're destroying the earth. Well, there's a whole lot of earth, but you don't have a whole lot of lid margin. And the bacteria are absolutely destroying it and making it so that they don't have an environment in which they can thrive, per se, where the biofilm can continue to go. Now, that being said, there is still inflammation present. It is still wreaking havoc on this patient. It's still altering their life. And I want to give you guys evidence of a staged disease process. So folliculitis is pretty easy to understand, but we hear a lot out there in the medical community. Aqueous deficiency versus meibomian gland dysfunction as two separate disease processes. Okay. And I'm sure a lot of you guys out there have been diagnosed with one or the other, probably not both. I want to show you the evidence that it's a staged disease process and not separate diseases. Lipid deficiency. This is when you guys go into your doctor and you say, my eyes are watering all the time, all the time. Don't know what to do. And then your doctor looks at you and explains about the components of the tear film and whatnot, and explains to you that you are missing the oil layer. And we see that all the time. What we don't see is patients that go into the office and say, hey, I have healthy oil just streaming down my face. It's oil, 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 completely fine on oil. What I don't have is a water component. And the reason for that is because it is not a separate disease process. It is a staged disease process in which the meibomian glands are affected first, and then they affect the water aspect. Any of you that have aqueous deficiency, if you were to be tested on your meibomian glands, chances are they're not producing what they need to. Okay, it's not a separate disease process. It doesn't align chronologically, and this is something that doctors need to understand, because if it's a staged disease process, we can catch it early. We can look at earlier signs of it and say, hey, I don't want my patient to get meibomian gland dysfunction. I don't want my patient to get aqueous deficiency or lacrimal. I can catch them at the folliculitis stage. I can get them before they can even get folliculitis if we start doing some preventative care and preventative maintenance. We'll talk about this guy here in a second, and then I want to talk to you guys about preventative maintenance. Now, I know that for a lot of you, it's a little late in the game for that because you've obviously been diagnosed, but I want to talk to you about that model. So this guy right here, this is Demodex. Don't know how many of you guys have been diagnosed with this, and something that's kind of laughable is Demodex blepharitis. Now, I'm not saying that they don't play a contributing factor to blepharitis. They absolutely do, but they're not a causation for it. This biofilm is. So going back to one of the first slides I presented, this biofilm is a polysaccharide. It's a sugar substance. It is cake. It's a good food source for Demodex. And just to give you some background on these guys, Demodex live within the lash follicles. So they have a nice structure, nice protective structure for themselves, especially when the biofilm kind of reaches over the lash follicle. It protects them. They can constantly just turn their head and eat the biofilm that's right there for them. Big problem is they are nocturnal. So when we are doing our Demodex treatments, we're only able to do what we can during the daylight for them. Something like Blefx, which I'll get to here in a second, as one of the treatment options. We're obviously not doing these in-office Blepharitis Blefx treatments at night. So something like a mitricide or a tea tree oil does need to come into play to actually go after the population, where something like Blefx will remove the food source for the Demodex, will remove some of the ones that are scattered about. Okay. Demodex don't have a long life cycle, but they eat and eat and eat this biofilm. And if we were to use something like Blefx to remove the biofilm and the Demodex go back onto the lid margin, well, they're going to die. They're going to decompose and reintroduce not just their compost into the environment, but they're also going to introduce the biofilm again. Blefx. This is something I wanted to talk to you guys about. This is the treatment that takes care of biofilm. It's where you go into the office and the doctor uses an instrument that spins a microsponge that is saturated with a surfactant or soap-based solution along the lid margin, and it results in a complete and thorough removal of the biofilm. It's recommended, depending on your disease process, depending on your diagnosis, every 4 to 6 months. It is a private pay, you guys. Most doctors charge between $150 and $250. If any of you guys are interested, I'd be more than happy to talk to some of the doctors in your area and find out what their pricing is. And I can talk to you more about the procedure. The most important thing is this removes the source of inflammation. Any of you guys that are on lid scrubs right now, I challenge you to look at the instructions on your lid scrubs and look at the directions. And if it doesn't say close your eyes, let me know, because that would be the first commercial eyelid scrub product that I would come across that doesn't say close your eyes. And we've been talking a lot about this biofilm, and we know that it covers both the front and back, the anterior and posterior sections of our lid margins. And if the lid scrubs are only designed for you to use it while closing your eyes, we're only superficially cleaning. Plaque on your teeth, like I said, that's a biofilm, and it grows on the front and back. Imagine if I was your dentist and I wasn't doing an in-office cleaning for you, wasn't doing that deep cleaning. I was only telling you to brush your teeth. Well, I tell you to go home, but I'm telling you to only brush the front of your teeth. And that's what your eye care provider that's sending you home on a lid scrub right now is doing. They're telling you to only brush the front of your eyelid, and this biofilm exists all over. This right here isn't for you guys. This is just how to do the treatment. I'm going to skip over it because obviously this is an in-office treatment. You need a medical professional, whether it's an ophthalmologist, optometrist, or their medically trained staff to do this. Removing the biofilm anterior and posterior is not something that can be done at home. And I'm sorry to break that to you guys. There's no commercial over-the-counter product that is out there that is going to remove the biofilm. Blepharitis is exfoliative and atraumatic. Anything that you try doing at home always carries the potential of being traumatic, especially when you talk about the posterior section, talking about those inflamed glands. Inflamed glands, I'm talking about the globe, your actual eyeball. Blepharitis is a complete removal of the biofilm and debulks bacterial density to below quorum sensing numbers. So a lot of big words there, but essentially what it's saying is we're not sterilizing. We know that this bacteria is going to come back. It's naturally occurring. It's naturally forming. But what we're doing is we're removing everything that they're building so that they can't build to the point where they're going to take over your lid margin. Okay. Once again, it's a private pay procedure. Eliminates the source of inflammation. Does not do anything within the meibomian glands or lash follicles. Something like Lipoflow or Ilux needs to be used for that. Blepharitis does not do heat and expression. And these are just some before and afters. And I did want to get out of here real quick because I know that we had some questions. So let me pop over to those real quick. Can someone directly go into stage 2, skipping stage 1? Never had lash loss. So that is a fantastic question. And I'm going to answer that with no. The reason for that is just because you don't have lash loss, just because you don't have mattering, does not mean that you did not have inflammation at some point or time. Edema. You can look at a 12-year-old right now and they'll have edema at their lash follicle. That's the start of inflammation. I'm 33. Let me pull up this picture. Let me find this other deck. Sorry. Turn to list. It's in here somewhere. It's always the last place you look, guys. Oops. Nope, not that one. This one. Okay, so I want to show you real quick the answer to your question right there. This patient right here is a 33-year-old male. He's not symptomatic and doesn't use any prescription or over-the-counter aids, and he's not presenting with scurf, which we know is now not a great definition, not presenting with plaque or biofilm. But this patient absolutely does have inflamed vessels. This patient absolutely does have edema. So just because they're not symptomatic in this stage 1 doesn't mean that they don't develop it. And that's something that's very important in the medical community needs to understand, is that this patient right here is absolutely treatable. We can treat this patient right now by removing their biofilm and not allowing them to get to stage 2. What I like to equate to it is, you guys, I've been talking about plaque on our teeth a lot. Imagine I'm your dentist, okay? And you come into me and I notice that you have plaque on your teeth. Well, I decide not to say anything to you and not to do any in-office treatment. And heck, it's not bothering you. So I'm not sending you home to do anything. Well, you come back a year later for your annual checkup, and now this plaque has turned to gingivitis. And it's bothering you a little bit. So I say, okay, well, I can send you home on some brush your teeth. I'm not going to do anything in office, but I want you to go home and brush your teeth. Okay, so you go home and you brush, and it doesn't do any good because you still have this plaque buildup that's not going away. So this gingivitis now turns into gum disease. And you come back to me as your dentist with gum disease a year later, and I look at you and I say, I thought I told you to brush your teeth. You're not brushing your teeth like I told you to. This is your fault. It's not my fault. It's your fault. You're allowing your inflammation to progress. So you go home and you keep brushing your teeth. Well, now this gum disease, it's taken over and you start to lose your teeth. Okay, you have lost your teeth because nothing's being done about this plaque. So you go, I mean, the logical thing to do would be to go to another doctor, find or a dentist, find a specialist, and that specialist, somebody that is knowledgeable about biofilms is going to look at you and say, hey, way back when you had plaque on your teeth, if we had done something about it then, you wouldn't have developed blepharitis, you wouldn't have developed gum disease. I'm sorry, gingivitis. I'm mixing it, but that's because it's the same process. You wouldn't have developed gingivitis, and if you didn't develop gingivitis, you wouldn't have gotten gum disease, and if you didn't get gum disease, you wouldn't have had your teeth fall out. I'll show you another slide real quick. Oops. This right here, you guys, parallels to the dentistry model. So on the left, we're looking at the dental model. On the right, we're looking at the ocular model. So at the beginning, we have this formation of plaque or biofilm, interchangeable words. And if we allow this plaque or biofilm to exist over a long period of time, well, we develop gingivitis or blepharitis in the ocular model. Over a long period of time, that gingivitis will turn to gum disease, periodontal disease, and blepharitis will turn into dry eye disease. Well, if gum disease or dry eye disease exists over a long period of time, what's going to happen? Our teeth are going to fall out, or our tear glands or lashes are going to fall out, which a lot of you are dealing with. So it is the same process. So let's look at real quick what the difference is. Who taught you guys, and you can just chime in on the questions. I can see it now, so I can see who's asking what. Who taught you guys about good oral health and oral hygiene? Anyone? All right, well, I'll tell you guys. My mom and dad did. They taught me about good oral hygiene. They had me brushing my teeth at a very young age, and I was going to the dentist, and they said, brush your teeth or they're going to fall out. Well, who taught you guys about good lid hygiene? Well, it was probably your eye care provider, and usually it's only after you've been diagnosed, and usually we're diagnosing once again too late. We're diagnosing after you're at a late stage folliculitis, after you're symptomatic and problematic. When was the first time you guys heard the word gingivitis in your lives? I remember being a lot younger, seeing those Listerine commercials and hearing the word gingivitis, and I didn't know what it was, but it doesn't matter because I knew that it was bad and I knew that I didn't want it. Patients usually hear the word blepharitis after they're diagnosed. And they're usually, once again, diagnosed too late after they're heavily symptomatic, after it's an uphill battle. And patients' compliance with home care. We're overly compliant in the dental model, and we consider dry eye patients that we send home on lid scrubs to be notoriously not. Patients compliant with in-office cleaning, it's routine in the dental world. You go to the dentist and get deep cleanings. It's relatively unheard of in the ocular space, unless you're a patient that gets BlephX, that gets LipiFlow, gets these deep cleanings for your margins. So what's the difference? Why? Why is it so problematic? Well, you guys, it's education. You're educated at an early age about the dangers of bad oral health and where it will lead, but nobody really talks about ocular health and hygiene. And it's allowed to get worse. And the only time we have a real conversation is at the point where we're having to treat, and we're having to treat in an uphill battle sort of way. So it's very hard to do. And let me see. And Dr. Reinerson, I was able to unmute you. Can you hear me?
Yes, I can. Can you hear me, Chris?
Yes, sir, I can. Hey, you guys, I do have Dr. Reinerson on the line here with us. I do have some questions here, and once again, like I said, we can talk about signs and symptoms. The good doctor cannot diagnose anybody without doing any sort of exam, but we can talk about what we've got. So the first question, if you want to, if I missed anything there, doc, um, we had a patient or a attendee that said, "Can someone go directly into stage two, skipping stage one?" They never had lash loss.
Hmm. Yeah, well, they might not have lash loss, but it's a guarantee they'll have folliculitis.
Right.
And if the folliculitis goes on long enough, they will get lash loss. So the folliculitis is sort of the canary in the coal mine. Once you know you have edema and inflammation of the base of the lash follicle, you've got an inflammatory biofilm, and that will lead to meibomian gland disease. But it's kind of a sneaky aspect of the disease. Even doctors still really don't know how to look for folliculitis. So many times they'll diagnose the meibomian gland disease, not realizing there could be rip-roaring folliculitis right in front of them. So no, you really can't skip stages. Folliculitis is always going to be first. Meibomitis is always going to be second.
Right, and kind of to compound on that, doc, I've seen a lot of doctors really get excited about their MGD, meibomian gland dysfunction diagnosis, and they're so hung up on that that they don't. At that point, they no longer care about the lash follicles because we've got disease, we've got something that's affecting quality of life per se, and they're not scaling back and looking at these lash follicles to see, hey, this patient does have swelling there, so it is
Well,
present there. It might not be life changing.
that's right. Well, truth be told, we doctors have never been taught to diagnose folliculitis. We were never taught to pull the slit lamp back and look for folliculitis, or even care about folliculitis. I mean, it's just the lashes, right? So number one, we weren't taught to look for it, a diagnosis, and number two, what are you going to do about it anyway? So doctors would just typically ignore it or not even look for it, not realize it's there. But meibomitis is certainly more evident, more obvious. It becomes symptomatic, so that's what doctors would focus on, missing the earlier signs of the blepharitis, the first sign being the follicles being involved.
Right. Let me see. Next question is, my doctor has me on Tobradex. Is this safe or effective?
Well, it's safe. It's a combination steroid antibiotic, but it's really not going to do anything for the disease. People will sometimes get a real short-term symptomatic relief because the steroid quiets down inflammation. The antibiotic will kill off some surface bacteria, but the bacteria that live in the biofilm, the antibiotic cannot get to them at all. So they still thrive. And as soon as you stop the drop, the inflammation comes right back and the damage starts again. So Tobradex isn't going to get you anywhere, whoever's using Tobradex. Now, if you have your biofilm completely removed, then Tobradex is a nice choice. Now you're adding steroids to quiet down inflammation. You put a stop to the source of inflammation, and you're adding some antibiotics to kill off any remaining bacteria living on the surface of the lid. But that's a nice choice after a Blefex treatment, as long as it's short term. And maybe a week at the most you want to use a steroid or a steroid combination drop after a Blefex treatment. Then you're really not going to need it anymore. The inflammation will slowly go away on its own, and you get back to having healthy lids again. But nothing works unless you have your biofilm removed first. That's the critical part, and that's been the missing part in eye medicine for decades.
And also with that, not just Tobradex, you guys, all of the different pharmaceutical agents that you might have been prescribed. I'm sure I've seen a lot of you guys in those chat groups that have been prescribed Restasis or Xiidra. They're only able to penetrate so far. This biofilm, once again, it's impenetrable by our own human host response. It's impenetrable by antibiotics. So you can imagine that your Restasis, your Xiidra, your Latisse, all of these things aren't able to truly penetrate in the way that they're being sold to you because you have this biofilm blocking deep penetration. What exactly causes the grittiness in the eyes? That's coming from Ruben.
Well, that's just the chunks of biofilm that are sloughing off, that are getting pulled off the lid or crusting off. Sleep. When we wake up in the morning, the sleep you get in your eye, that's accumulated biofilm and debris that accumulates in the eye. after a long night's sleep when you're not blinking, you're not moving the eye. So it's the biofilm that causes the grittiness. I mean, imagine having little bits of rock candy ground up and dropped in your eye. It would feel gritty. This biofilm is a polysaccharide, and when it dries out and you get the crusting along the eyelid, it's just like rock candy, and you feel that gritty feeling. You have to get rid of the biofilms. Biofilm explains everything we see clinically on the lid margin, and it explains everything the patients feel symptomatically.
Okay, let me see. Apart from Blepharitis or antibiotics, are there any other ways to reduce biofilm?
No, not really. You have to physically remove it. Biofilms are impenetrable. Bacteria have been building biofilms for eons longer than we've even existed as a species. And biofilms being built to protect these bacteria. Bacteria aren't as stupid as we think. They build the biofilm, nothing can get to them. And when they spend 30, 40 years building a biofilm on any surface, let alone the eyelid margin, they don't want to easily get sloughed off or washed away, right? They're building this biofilm, that's their home, that's their fortress. They want to build it on solid ground and they don't want to get sloughed away. So they actually super glue themselves onto the surface. So there's no way to get rid of these biofilms with any kind of a drop or solution. You have to physically remove it. And the only thing that physically removes it thoroughly is a Blepharitis tip. Now you can take some doctors will take a metal spatula and scrape the lid, thinking they're scraping off a bunch. That's like trying to scrape dried maple syrup off your breakfast table the next day after you realize you spilled some. You're going to get some off, but you're going to have a sticky mess. It's not going to really have any impact on the disease. So a thorough Blepharitis treatment is the only way to effectively remove the biofilm.
Okay, Ruben's got a follow up. At what point should you consider doing the LipiFlow procedure?
Well, that's going to be a question for your doctor, but after you've had a Blepharitis treatment. Many people early on were getting LipiFlow treatments without having the surface biofilm removed, and it wasn't as effective as it could be. Once they get their biofilm removed, the effectiveness of the LipiFlow goes way up. So anytime after you have a Blepharitis procedure, it'd be a good time to get a LipiFlow if you have obstruction of your meibomian glands. And by the time it's recommended that you get a Blepharitis, you typically have obstruction of the meibomians. So it's really a good thing to do. Once a year LipiFlow, Blepharitis every 6 months, every 4 months if you have bad disease.
And I kind of want to brush up on that, you guys, because in these groups that we conversate about all these things, I have seen, and I've discussed with quite a few patients that have said they've gotten LipiFlow and they didn't get Blepharitis with it. If you're spending this kind of money on something that you are doing to better your health, I recommend that if the doctor does not do a combination of Blepharitis and LipiFlow, to continue looking for a doctor that does, because there are studies that are coming out showing you the efficacy of Blepharitis and LipiFlow versus efficacy of LipiFlow by itself, and it's tremendously different. So these are things that need to be done together, and this is something that even LipiFlow, their company, they say that it needs to be done. Blepharitis is a good combination with their product because it's going to make theirs work better. So if you're spending, gosh, I've seen some outrageous prices out there, but if you're spending anywhere from $700 to $1,200 on a LipiFlow procedure, make sure that they're doing everything that they can to give you the most effective treatment. Oh, and should you have Blepharitis before LipiFlow? And Doc, I can handle this one. Melody, yes, absolutely. Because with Blepharitis, we're removing that obstructive biofilm, that inflammatory obstructive biofilm, which will make the heat or the expression from the heat easier for the LipiFlow. So it's not like you're pressing against a blocked gland, which could be slightly traumatic. Now you're making it so that that diseased product can be liquefied and easily expressed out. There's no real resistance. Okay. And you guys, do we have a couple more questions? I'll give it a second because I know that you guys have to type it out. Okay. Well, oh, there we go. We got one from Ruben. At what stage is it too late for meibomian glands to come back?
I'm sorry, what was the question again, Chris?
The question is, at what stage is it too late for meibomian glands to come back?
Well, once they're fibrosed and scarred, they really can't come back. There's no way to really determine that, though. We have no real diagnostic capability of looking at a meibomian gland and saying, well, there's a chance we could get that one back, and oh, that one's fibrosed and scarred. So that's a real difficult thing to determine.
All right. And apart from Blepharitis or antibiotics, is there any other treatment to kill biofilm?
Nope. Again, nothing penetrates biofilm, and it's that way for a reason. It's like Kevlar armor. Nothing penetrates it. Antibiotics can't penetrate it. Our own white cells can't penetrate it. Even a surgical scrub before cataract surgery can't penetrate biofilms. There's nothing to kill these things. They're that way on purpose. Again, bacteria don't go away easily. And if you know anything about general medicine and about wound healing and wound disease, you'll know that biofilms are really the bane of the wound surgeons, because that's what makes some of these wounds non-healing is the biofilm, and they're just very difficult to get rid of in all aspects. The best thing is to remove it physically and then keep it gone, getting regular treatments. But you have to physically remove it. Luckily, the eyelid margin is somewhere where we can physically remove it. I mean, think about an open wound where you've got necrotic tissue, you've got live tissue, you've got that irregular surface of an open wound. Very hard to get biofilm out of that. But the lid margin's relatively smooth. We can still remove biofilm from that. That's the critical part.
Okay. And the next question is there any lab which measures the quantity of biofilm on lids?
Nope, we have no way to measure that yet.
Now there are tests out there that will show inflammation and whatnot. So obviously, we can quantify that you do have inflammation. A lot of you guys, I'm sure we could look at you with our naked eye and say, heck, you have inflammation. But all those things are contributors that are caused down the road from biofilm, but anything from biofilm itself. You guys, do we have any more questions? Okay. So the oral doxycycline I have been taking is no longer helping me. And that, Ruben, that's kind of what we said before, is that it's short term, and especially if you've been on it for a long period of time, and correct me if I'm wrong, Doc, would you build up some sort of resistance to the antibiotic?
No, it's not so much resistance. It's just doxycycline has an anti-inflammatory component on the meibomian glands, and it does kill bacteria, but it doesn't stop the bacteria. It doesn't stop them from building biofilms. So while you may get a little bit lessening of your inflammation of the meibomian glands, it doesn't stop, and it keeps going, and eventually your meibomian glands are dead. It just might take them a little bit longer. So if you're on doxy, geez, you have to get a Blepharitis and you have to get a LipiFlow or an Ilux to heat and express those glands to get all the biofilm out of the glands that you possibly can.
Yeah. Is Blepharitis available in India?
In India, I'm not sure if we have any in India or not. Chris, that's a better question for you. We're in just about every country around the world, but I'm really not sure we're in India. We might have one.
Because I know that you're in Pennsylvania. Are you looking for friends, family back home, or what? What are you looking for with that, Shaka? For family, okay. And that's something I can look into that, just to see if we've got any doctors. If you could, and I'll give all my contact information at the end of all of this. But if you could just tell me where in India, I can see if we have any close doctors. But we'll certainly get you set up in Pennsylvania. And with the email that you sent earlier, I'm actually going there the week after Christmas to do their training, so they'll be up and running from then. Okay, and I know that they're scheduling out now. So if you wanted to call that office, it's Nittany I. call that office and see if you can get worked in, okay? All right. How do I find a doctor that does BlephX? Is there a list? Melody, I am your contact for that. So there's multiple ways you can do it. You can go to our website, and we're doing some revamping there. So it says find a doctor locator, and it's essentially what you have to do is you write in, and I will give you options on your local BlephX concierge doctors that will offer a discount on the procedure. And these are doctors that have gone through training. And in addition to that, I will also give you some of the doctors that might not have gotten, might not offer a discount, but are still local to you. So Melody, make sure to grab my contact information from the end of this presentation, and I will be able to direct you to where you need to go. Warm compresses. Do warm compresses help very much?
Warm compresses help with some symptoms. I think people feel better after using the warm compress. The theory there is that it helps liquefy that sludge-like component of the meibomian within the meibomian glands. So if you're catching this disease relatively early and it hasn't turned into total solid toothpaste yet, you can get a little bit of meibomian expression, meibomian oils, by using the heat. But that's about all it's going to do. More of a symptomatic relief if you catch the meibomian gland disease early, but don't think it's going to do anything as far as stopping the disease process, and certainly not reversing the disease process. If you enjoy warm compresses, they feel good, do it. It doesn't hurt anything, but don't think it's going to help very much at all.
Are contacts a main culprit for growth of biofilm excessively?
Absolutely, yes. That's one of the biggest risk factors there are, except for age. The second biggest risk factor is biofilm. And if you've been in contacts for any length of time at all, you have a significant and aggressive biofilm already. Sometimes I used to do a lot of LASIK surgery, and I would see, an 18 or a 20-year-old come in with horrible folliculitis and early meibomitis, and I could just back up and say, so how long did you wear contact lenses, without even knowing their history? And every time, oh yeah, I wore contacts for a year. Sometimes I'd hear, oh, I only wore them for 6 months and then I had to take them out. Well, that's all it takes to speed up a biofilm. Just having the contact lens in speeds up the growth of bacterial biofilm, because a contact lens gives the bacteria some place that they can go and avoid the host response. So they can divide and accumulate more quickly on a contact lens, because there's no inherent blood vessels, vascularity, white cells. There's no system-wide immune response in a contact lens. It's inert. It's an inert object sitting on the eye. So it really gives the bacteria someplace to go where they can really, really divide much more quickly and make a thicker, aggressive biofilm. Now, I'm not anti-contact lenses. I'm just saying if you're wearing contact lenses, that's a big part of your problem, and that speeded up the process. You're going to have a thicker, earlier biofilm. Get your biofilm removed and keep it removed every 6 months. If you're in contacts, you should get that biofilm cleaned off. If you're not going to get your biofilms removed, then I would go out of the contact lenses. For any of you that are listening that have been in contacts before and you had to get out of them because you just were symptomatic all the time, and your doctor maybe told you were intolerant of the contact lenses, for anybody that's been through that, get a BlephX, keep your lids clean. After about a year, try your contacts again. You might be surprised that you can go right back into them.
Okay. Next one, how does hypochlorous acid or cold water provide me symptom relief when I spray on the lids?
Yeah, hypochlorous acid. Supposedly, the hypochlorous acid neutralizes some of the toxins that the bacteria are producing. It also is claimed to kill some of the bacteria. It has about a 30-second activity life, so it can't do a whole lot, but it's kind of like warm compresses, in my opinion. It makes you feel better because it neutralizes some of the toxins, but it's not going to do a whole lot to affect the biofilm.
Okay. So you guys, if I'm going to give it 2 more minutes of questions, and then we'll kind of cap it off, because I know some of us are on Eastern time, if not later. Does organic vegan diet help to reduce the biofilm apart from BlephX?
No, doesn't affect 1 iota. Bacteria don't care what you eat. They just want you to eat so you'll stay alive. so they can stay alive. But they could care less about what you're putting in your body. As long as they have a surface and they have moisture and they have those inherent nutrients in your tears, they're happy campers. They could care less.
Okay. All right, you guys. Well, I'm going in the chat box. I don't know if anyone can see this. So I'm going to put my contact information, my email. A lot of you might already have it, and if you've actually joined us through the Facebook groups, you're more than welcome to reach out to me on there, and then I can direct you to my professional response. But feel free to reach out to me literally at any time. I will. I will. If I don't have answers for you, I will find answers for you. I will help you with this. We understand here at BlephX, we are not just a instrument by any means. We are a complete overhaul and rethinking understanding of the entire dry eye and blepharitis syndrome process. There are too many failures across the board right now in the medical community of taking care of this epidemic. And I'm sure you guys can attest to that. There's not enough help. For every one good dry eye specialist out there, there are probably 40, 50 optometrists, ophthalmologists that aren't taking this disease process as serious as they need to. So that's why we are really going to you guys and helping educating patients, but also educating doctors as well. And real quick, Melissa, you haven't chimed in. I'll get your one question answered. When I massage my lids with anti-inflammation EMU oil, I gently rub lids with my fingernail and it feels wonderful. Okay. And there's a lot of things that people can do. I mean, I've seen them do all sorts of kind of cheeky things that give them wonderful relief. Some people would use like tea tree oil and whatnot. So you're doing something, but it's going to come back, and it is coming back. And that's why something like BlephX, removing of the biofilm, just like removing of plaque on our teeth, I can use Listerine and my teeth feel great and my breath feels great, but this plaque is going to build up and eventually I'm going to get inflammation. And once the inflammation hits the structure itself, it's going to spread. It's going to spread like wildfire. So we need to address it at the source instead of just doing Band-Aid solutions. Do BlephX providers usually do the procedure on the first visit, Ruben? It really depends on their setup. I know a lot of offices will schedule it out just for the fact that they want to do a medical evaluation on you first, obviously. So they want to be able to dedicate the proper amount of time instead of rushing you into their schedule. That being said, I know a lot of offices, because it doesn't take long to do, about 6 to 8 minutes for the procedure. A lot of offices will work you in same day. It really just depends on the office that you go to and their scheduling setup. Okay, well, you guys, I want to thank Dr. Reinerson. I know it's late for you, and you've had a long day. I wanted to thank you for jumping on and answering this Q&A. You guys that hopped in, I want to thank you guys for listening to me ramble for the last hour and 20. I will make this a recorded session, and I can give it to you via email if you want to revisit it, and I'll also post it in those groups as well, just so you can tag friends, family, whoever you think would benefit from hearing this. So once again, I thank you guys so much. If you have any additional questions, once again, my email is Chris, CHRIS, at Blephx, BLEPHEX.com. Feel free to reach out to me. I'm on the road for the remainder of this week, but I will do my best to answer your questions and concerns as soon as humanly possible. Okay, so once again, Chris, CHRIS, at Blephx.com, and I can follow up this presentation by sending everybody an email with my contact information as well, okay? All right, Doc, well, I thank you for...
Thank you, Chris. Thank everyone for tuning in tonight. I hope you learned something interesting and new about dry eye disease. Go out there and get your BlephX done and start feeling better.
All right,
Bye-bye.
Thank you, guys. Thank you. Everyone have a fantastic night, and I will get you my contact information. Bye-bye.